Hello everyone, I'm Kevin Bozick, the William R. Murray Professor and Vice Chair of Orthopedic Surgery at UCSF. I'd like to welcome you to the last session of Transparency, Consumerism, and Value in Orthopedics, a three-part series on the delivery of market-informed, value-based care, jointly presented by Cleveland Clinic and Castlight Health. The topic we will focus on today is high-value hip, knee, and spine surgery, behavior change and insights for delivering high-value care. So now it's my pleasure to introduce you to our distinguished faculty. Dr. James Robinson is the Leonard D. Schaefer Professor of Health Economics at the University of California, Berkeley. Dr. Joe Zuckerman is Chairman of the Department of Orthopedic Surgery at the Hospital for Joint Diseases, New York University Langone Medical Center. And Dr. Joseph Iannotti is the Professor and Chair of the Orthopaedic and Rheumatology Institute at the Cleveland Clinic. Okay, gentlemen, let's get started by quantifying current and future national demand for hip and knee replacement. Joe, can you give us a comment on that?
I think everybody expects, given the past record of increased volume and the aging of the baby boomer population, that we're going to see probably somewhere around a threefold increase in the current volume of hip and knee arthroplasty. So there's approximately 1 million hip and knee replacements done in the U.S. each year. And so probably by 2020, 2030, it's going to be somewhere between 3 and 4 million hip and knee arthroplasties each year. So one of the more common or most common procedures in the U.S.
So Joe Zuckerman, what are the factors that are driving that increase in volume in terms of demand, appropriateness, technology, training, et cetera?
Well, the demographics of the population is a primary driver. People are living longer, they're more active, and they expect to be able to continue that activity. In addition, injuries at a younger age have now led to, or our ability to replace joints is now extended into a much younger age group. 20 years ago, you would say, well, you really don't want to do a hip and knee replacement unless you're, 65, maybe 60, 70 even, all right? That's been driven down. It's not uncommon to do hip replacements to people in their 20s. We know it can be successful. We know that patients want it, and most importantly, it's a good solution for it. It has a dramatic impact on quality of life. So the combination of all these factors has driven these numbers way up.
So given the fact that groups like Dartmouth have shown that much of orthopedics, and hip, knee, and spine are no exception, are quote-unquote preference-sensitive care, Joe Iannotti and then maybe the others can comment as well, how much of this change in volume is so-called supply-sensitive? So Dartmouth has shown that your likelihood of having a procedure and the volume of those procedures varies by zip code, which is different from the prevalence of disease, independent of the prevalence of disease. How much of the change and the increase in volume in hip, knee, and spine care is related to this supply-sensitive care that the more surgeons we train, the more of these procedures will be done?
I think that's true. I think the points that Joe made are very much true in terms of why there's been increasing numbers of cases done, but I think it is based on access. And the more surgeons that are in a general area, the more availability there is for patients. The studies that have been reported have gone both ways in terms of interpretation. Some of them have thought that there's underutilization in some areas. There have been some socioeconomic analyses to suggest that maybe in some areas of the country there's underutilization of hip and knee arthroplasty. But certainly the number of surgeons, the number of access points is a driver. Particularly in urban areas where their patients have different demands than maybe in rural areas.
Jamie, do you want to comment on other stakeholder perspectives on this supply-sensitive care issue and how much of this care is quote-unquote appropriate, or how much it is driven by increased supply of physicians in certain markets?
Sure. I think that from the perspective of the payers, the insurers and the employers, there's a difference in perception between knee and hip replacement on the one hand and spine surgery on the other. because it's as perceived. There is more clinical uncertainty and about appropriate use of spine surgery. And so the appropriateness issue is a bigger deal in the eyes of the insurer over the spine work than it is in the knee and hip. Knee and hip is very much, I think, perceived a lot as patient preference driven, really. How much pain can you tolerate? What are your functional needs? How active are you? Things of that nature. Whereas spine has a lot to do, there's severe pain, but the actual cause of it is uncertain and the outcomes are much more, it's more controversial. So I think that the insurers are somewhat more, I would say, aroused about the spine surgery than they are about the joint surgery.
Well, I'm glad to hear you say that, because as a hip and knee surgeon, I love villainizing the spine surgeons. But in truth be told, if you look at the Dartmouth Atlas, there is a surgical signature, so to speak, for both hip, knee, and spine procedures. So there is variation. And I want to make the point that a lot of times people view variation as a bad thing. Variation is not a bad thing, but when there is variation in utilization of procedures, that variation should be driven by patient preferences and values, as Jamie alluded to, and not provider preferences and values. In other words, we shouldn't have different triggers and thresholds for when it's appropriate to offer surgery, but the patient should have input into that decision. And so we do not expect to see flat utilization throughout the whole country, because depending on the population, they're going to have different norms and preferences about what their expectations are for what they can put up with in terms of pain, what types of functional activities they expect to be doing at their age, et cetera, et cetera. People in New York City are going to have different expectations than those in the Midwest and those in California. Let me shift gears and ask Joe Zuckerman a question. How is evidence-based medicine and the availability of, say, systematic reviews and clinical practice guidelines from AUS and others, how's that changed the delivery of hip, knee, and spine procedures?
Well, for those that have been doing this over the course of a few decades, it's dramatically different. In fact, it's dramatically different how we do things now, even from 5 years ago. And it starts with the evaluation of the patient. Now you have better means to stratify risk ahead of time, identify what patients are good candidates, what patients are not good candidates, or how to manage the risk. Simple things like antibiotics. We know antibiotics for more than 24 hours, right, is not necessary, right? It doesn't add anything, and maybe you can even go even less. The concept of mobilization of patients on the day of surgery, as opposed to the day after surgery, or in the old days, letting them recover for 3 or 4 days. VTE prophylaxis, how that has to be managed, because that's an important quality measure in many people's eyes, making sure that we have evidence to support the VTE prophylaxis method that we use. So a variety of things that have dramatically changed all the things that we do in caring for these patients.
Given that we have limited evidence, so there are certain points that you can use to make evidence-based decisions, and Joe covered most of them: antibiotics, VTE prophylaxis, and a few others. Beyond that, there's very little evidence. So how do you drive consensus amongst your troops? You're both at institutions where you've done a very good job of that. You can't use the evidence to go to your doctors and say, well, there's evidence that this implant is better than that. There's evidence that this physical therapy protocol is better than that. There's evidence. So most of this is really consensus driven in order to reduce the variability, and you can't rely on the evidence. How do you do that effectively at an institution level?
Well, I think it first starts at the institutional level, and the institutional level could be the department, it could be a section head, it could be the CEO of the health system. But I think what's different today than 5 years ago is a sense of urgency that we have to decrease variation, unnecessary variation, if for no other reason, so that you can at least measure quality and measure cost on a fairly consistent platform. So if you say, what's the biggest change, is the sense that we have to do that. And so then it becomes the next step is, how do you build consensus? And typically it starts off with a few thought leaders who are willing to put some sweat equity into putting together a document, a guide, something that says this is what we believe is the best practices. Some of it is evidence-based literature, some of it is experience-based. That then has to go through a fairly substantial vetting process with all the stakeholders. And the stakeholders are not just the orthopedic surgeons, they're every caregiver that touches that patient. As you said earlier, it's really care redesign that gets you to the final best practice. The third step, which is the hardest thing to do, is now once you've built this consensus and you've got this sort of bully pulpit document, is how do you then build that into the actual day-to-day practice to understand who is providing that care? Where is that being provided within the health system? When should it be provided? And that's the care redesign. And then how do you get people who were casually involved in the redesign process, they didn't drink the Kool-Aid from the first moment of the process, to actually implement it, and actually implement it in their day-to-day practice. And that takes months, even in a well-organized place like the Cleveland Clinic, where you'd say, well, pretty much everybody who does hip and knee arthroplasty gets a paycheck from the Cleveland Clinic. You would think, oh, that's a pretty strong motivator to get people to buy in and do what's being asked of them. It doesn't always work as quickly as you'd like. So it's a process, but I think it starts with either departmental, institutional commitment to say this is a necessary thing to do.
And Joe, you've done this very successfully at NYU with a very different practice model. What's been your keys to success?
Well, I think consensus is a very powerful approach to this. Because if you can get consensus, then you've got physician buy-in. And to me, consensus is a 90-10 rule. Consensus will take care of 90% of the cases 90% of the time. In other words, 90% of the situations will follow the guidelines that you set up. You want to leave room for the 10% variation. If we have a guideline that says if you're going to use an alternative bearing surface for a hip replacement, that patient should be either under the age of 55 or have a BMI of over 35 or 40, all right? Then but somebody says, you know, my patient's 57, all right, and he's very active, this and that. They have to have, that surgeon has to have a means to get approval or be considered to be the exception. If you do that, then it gives the surgeons a sense that they still have the ability to, or has the autonomy to make decisions about their patients. So you never get 100% buy-in, but 90% is a reasonable goal, and that allows people to drink the Kool-Aid comfortably, but at times, you know, to get a different flavor if they need it.
Well, I think that's a very critically important point, because physicians in general are used to autonomy, and the whole concept of quote-unquote cookbook medicine gets them very, very defensive. So they will grab onto and hold on to that autonomous decision-making, even if it flies in the face of evidence, even if it flies in the face of making their lives easier and the outcomes for their patients better. If you give them that out and the ability to understand, I'm still making the decisions, but educating them that actually driving standardization, there's inherent benefit just in terms of Deming's rules and just in terms of manufacturing theory. If we can standardize, that's going to provide benefits for all of us. Regardless of, we could standardize around, we shave the left eyebrow on every patient. It doesn't really matter what it is that we're standardizing around. If we can get everybody to do things in a similar way, it's going to make that data collection piece easier, and it's going to improve our outcomes just by definition. That's been shown in many other industries in addition to healthcare. Let me shift gears and ask Jamie Robinson, how are others looking at evaluating the quality or the value of these hip, knee, and spine procedures? So you've heard about what goes on and how the sausage is made and what goes on inside the institutions. From the outside looking in, what are other stakeholders looking at to define quality and value in these institutions?
That's right. Well, the first level of review is to look at what's available externally. That would be the publicly available quality metrics and the cost metrics. But then as they move more towards a center of excellence strategy, as we were talking about earlier, they'll want to go more inside. And they want to tell me about it. And they may have their own medical director. They can tell me about your care processes. How do you do it? What's your adherence? What kind of exceptions rules do you have? You know, just tell us about it so that if you're getting good results, it's because you're doing good things. It's not just a case mix issue.
And that's interesting, because the Joint Commission's specialty certification now is really based on the fact that you have a performance improvement, closed feedback loop within your institution. It's not so much based on your outcomes, it's the fact that you're measuring outcomes and you're using those outcomes to inform changes in decision. Let me ask a follow-up question on that to you and others on the panel. So we know that there's a volume outcome relationship in hip, knee, and spine surgery, and yet there's also this utilization problem and appropriateness problem. So if I'm if I'm a purchaser or an insurer, am I thinking that a place that does a high volume of procedures is going to deliver better quality to my beneficiaries? Or I can name certain regions of the country where we know there's overutilization of, let's say, spine procedures. So does that high volume indicate that they have a lower trigger and a lower threshold and they're doing more inappropriate surgery? How do we balance those two objectives when we think about where we want to send our beneficiaries?
Right. Well, I think there's two different issues. One is what we call the population-based rate, and that's where the appropriateness really comes in. An idea you could have an area which is very low population-based rate, but the hospital is doing one hospital is doing all the work, so they have very high volumes, and so that's not a problem. I do think that a good marker of, from the point of view of the purchaser, of a center of excellence is that when a patient is referred there, they go through another appropriateness review. And if that hospital sends back some of those patients and says, you know what, they don't need this procedure. They could use medical treatment is fine for this patient. That's an indicator that this isn't just purely a revenue gain that they actually, and so that is another quality indicator, if you will, an appropriateness criterion, a process, some sort of a process, formalized process, and some evidence that actually some patients are sent home.
But hospitals are not sending them back. It relies on the individual physician to do that, right? To see the patient and say, you know, you don't need this, or you do need this, right? This procedure, which again gets at its lowest level, foundational level, is the physician who's going to make these decisions. The hospital is just there to provide the vehicle.
The hospital
to
group,
the
like for
care.
example, at the Cleveland Clinic, my understanding is they are National Center of Excellence for cardiovascular procedures for a number of large employers. And as part of the contract, the patients are referred in from wherever they come in. They do have to go through some sort of an appropriateness review here, not by the hospital administrator, but by the cardiologist. Right. And some of those patients are in fact sent home and said, well, the medical treatment is appropriate for this patient. They don't need the cabbage or whatever the person. And payers like that kind of stuff. They kind of go, oh.
Yeah, that's what we've learned with this National Orthopaedic and Spine Alliance. So we built out a physician-owned, physician-managed national alliance for orthopedic and spine procedures. Right now it's five groups that are part of the alliance, and it's hopefully going to grow to 10 or 15 in the next year or so. But every insurer, every employer that we've contacted about participation in the national network, it wants to know exactly that. What are the checks and balances? How does this alliance manage these centers of excellence? Most centers of excellence that are designated by a typical commercial payer are isolated centers unto themselves. There's no central management, there's no central criteria, there's no central physician oversight, there's not necessarily even centralized data collection to look at the quality of the product line across the members of the Center of Excellence network. So one of the things that has resonated with our development of this alliance, Orthopedic and Spine Alliance, is the fact that they want exactly that. They want some ability for someone centrally to say, these are the appropriateness criteria, we're all going to follow them, we're going to monitor it locally and centrally, which is very different than the typical Center of Excellence networks. So we've seen that in the real world.
Yeah, and following up on that, then, how do we think about, at your various institutions, engaging patients in all of this in terms of this appropriateness? I mean, for instance, Joe Zuckerman at NYU, you've had a really successful move to getting patients out of the post-acute care setting and directly home. That takes a real sort of engagement and partnership with patients, because the knee jerk from the patient is, I want to go to somewhere else where someone's going to take care of me for longer. Why are you pushing me out of the hospital and sending me home? So how do we think about engaging patients on appropriateness, whether it's appropriateness for the procedure or appropriateness of where they're going to go post-discharge?
So 3 years ago, before we started our bundled program, I would have had very little to say about this, right? But as part of the bundle, we've had to engage patients throughout the entire bundle. And we do that through a care network that basically engages the patients. Once I decide that I think a patient would benefit from a hip or knee replacement, and they decide to go ahead, they enter the system. They're contacted ahead of time. We use a risk stratification tool for discharge planning purposes, a readmission risk tool to determine if they go home, what's their risk of readmission, and we've had a very good predictive value with this. And they're contacted by people along the way that basically get them involved. So a lot of times the conversations start off, well, what are your plans after surgery? Well, I want to go to a rehab center. Well, let me ask you a few questions, all right? And they go through this whole thing. It's an engagement. It's a conversation. And the vast majority see the benefits of being at home because they think they're going to go home and be on their own. We've intensified the home care services because we've partnered with various visiting nurse associations to make sure that the care provided at home is at an elevated level. And frankly, when I have discussions with patients about going to a rehab center, I emphasize the fact that I can't control what goes on there, all right? You're going to be there with patients of all different types. It's different than being in an orthopedic hospital like me or in an orthopedic floor like in most hospitals. You're going to be there with people of a wide variety of medical issues with staff that don't have the orthopedic expertise. They may be terrific, but they don't have the orthopedic expertise. To me, that opens them up for potential problems. And patients want to avoid problems. So that's how we've been able to drive down the post-acute care setting for the vast majority of patients, but not everybody. Clearly, if there's a risk stratification that tells us they need to go somewhere, that's what we do. Now, the other piece of that is your post-acute partners need to be partners. It's amazing how, I think Medicare has a 21-day rehab benefit, right? Amazing how some of these patients all of a sudden get better on the 20th day. Right, that they've been there.
But not
right?
until then.
Right, but not until then. So if my patients go to a rehab facility, I tell them 4 days. 4 days, our care coordinator, and even I'll be in touch with them to make sure they don't get stuck there, which invariably happens, and that's where the cost really builds up.
So to Joe Zuckerman, what responsibility do we have in disclosing the fact that we now have financial risk that we didn't have under the fee-for-service model to those patients? I'll give you an example. Yesterday I saw a patient who said, I really want a CPM machine after my surgery. I said, well, I heard you don't use those anymore because we did use them when she had her prior surgery. I said, we don't use those anymore. Why not? Well, because they don't improve outcomes. Well, I don't care, I want it. Now I have to disclose, well, actually, it costs money and it doesn't improve outcomes, so there's no use in using it. From the patient's perspective, I don't care what it costs. You're my doctor, you should be getting me everything I want. How do we think about that discussion with patients?
Well, so first of all, you have evidence that says this hasn't been beneficial. I would stand by the evidence. And it's a discussion with the patient. They may very well go somewhere else, right? That's going to have that done. And you have to accept that. Right? To me, it's no different than if a patient came to you who was told somewhere else that they need a knee replacement and you don't think they need it. If they say to you, but I want it, you're not going to do that operation, right? This is in the same genre as that response. So, and I think the professionalism that Joe alludes to, right, is very important here. We have to conduct ourselves in an ethical manner that reflects the social contract that we have with patients. Now, I also think that in terms of the disclosure, so when we started the bundle payment program, every patient gets a written description of the program. Right, that says we're involved in this, we're trying to do everything we can to improve care. And look at the name of it. It's not the bundled payment program, it's the bundled payment care improvement. All right. Now, you can say that's PR, but the fact is, in reality, we're improving care. I believe we're improving care, I think we all do. At the same time, we're decreasing the cost and thereby increasing value, you would think.
Yeah, I think that's a very important point that we have to reiterate to patients as well as other stakeholders, and particularly the physician community, that there is no instance where improving quality results in higher cost. In every instance, improving quality, by definition, lowers cost, and a better outcome is a less costly outcome, and we know that. But sometimes patients are of the mindset that more is better. Last question for you, Jamie Robinson. So how do, as we move into these cost-sharing situations, how do patients again think about this concept of appropriateness, and what are you withholding from me, doctor, because you now have a financial incentive to cut corners, et cetera, and I want more. More is better by definition, more care, more tests, more procedures, et cetera. How is that changing with the changing payment models?
Well, I think that, of course, there's two things going on. One is new payment methods for the physicians and hospitals of the type that you've been describing, but also on the other side, more cost sharing for the patient. And to some extent, you as physicians, you're more and more going to be confronted with, you suggest to the patient, I think you need this test or procedure, and the patient says, how much is that going to cost? And I'm not going to do it. The adherence issue is going to rise which has always been a problem with pharmaceuticals, but now I think in surgery you're going to see more of that.
I think one of the safety nets for this discussion is the benefit that comes from care paths. and having some kind of institutional
That you
buy-in.
can point to.
Right. So if you say, listen, why don't you use CPM anymore? It's not necessarily, Kevin Bozik's isolated decision not to use CPM. I mean, it's a best practices that CPM doesn't have the best evidence for its use, that it's high cost without any benefit. And so therefore you can say, listen, this is not a single person decision. It's a group decision. This is how we practice. If another article or some high level evidence shows that in this population of patients with this disease, with this knee, that CPM does work, we're going to use it, regardless of the cost, because there's a benefit.
And I think I think as both of you alluded to in your comments, having evidence and collecting data and making evidence-based decisions, that resonates with patients. They say, okay, tell me what the evidence says, as opposed to tell me what the internet says. But again, as long as we have this moral hazard problem with health insurance, which we do, the argument cannot be it costs more and there's no benefit, because that doesn't resonate with patients. I don't care what it costs. The only thing that resonates with them, in my opinion, is there harms. If there's no harms, give it to me, regardless of what it costs, regardless of whether or not you or your evidence think that there's benefits. But if there's harms, then that's something that I will consider. But the argument, in my opinion, that it costs more and there's no benefit doesn't resonate with patients in a third-party payer system. Okay, so we've talked a lot this morning about the role of healthcare providers, both hospitals and physicians, as well as post-acute facilities, in redesigning care to drive value. Dr. Robinson, what can health plans and purchasers do to drive value in healthcare?
Well, I think that their first goal would be to encourage their members or the patients to go to provider organizations and to physicians that are committed to care improvement and care design. Now, on top of that, realistically, some of the health plans are doing their own forms of care management or oversight of some of that more details, because as they look out at their claims data, they see this incredible variation. And so I guess that goes back to our earlier point, that the message to the physicians is, do care design in pathways or they shall be done to you.
So that relates to utilization review criteria. So from the payer perspective, and utilization review is sort of comes in and out of favor, but utilization review is essentially saying, here's our appropriateness criteria, you follow them if you want to provide care to our beneficiaries. How does that strategy differ in terms of effectiveness from, let's try to seek out providers that are implementing those systems internally and making the best decisions on behalf of our patient? Is there enough trust between the payer community and the provider community that we can handle that, we'll take care of the appropriateness on our end?
A lot of health plans really would like to and actively exempt certain provider organizations from oversight, because they believe those provider organizations are bought into the concept and they're doing it themselves. And so that we don't need to second guess. It's kind of like at the airport, you've got to go through pre-check. We've ascertained you don't have to take off your shoes.
Joe, the Cleveland Clinic is obviously one of those organizations. How do payers think about Cleveland Clinic in terms of this sense of preventative care and not overutilization? How does an organization establish that kind of a culture and reputation externally?
Well, first, it's varied by insurance company. So we have some relationships that are far better than other relationships in our market. The provider group, insurance group that we have the best relationship with in terms of commercial payer, we have sit-down meetings. We've had over the last year discussions about how to share claims data, because we need claims data to really build the proper bundle and understand what we can do to move their cost curve. We've had discussions, sit-down discussions about what they spend in personnel for utilization oversight versus what we spend. We've had discussions about what best protocols there are. We even had some discussions about how they transfer some of their costs to pay for some of our services for the purposes of not duplicating dual processes. So again, it's almost a similar paradigm as saying, how do providers that are in private practice partner, align with the facilities in which they practice? And so there's a little bit of a paradigm shift. There's an inherent distrust, without question, because of the fact that we don't want to sell the farm. We don't want to give away things that are inherent, especially if you're in an academic medical center. You've got costs that are substantially higher just by the inherent nature of where you practice. And a lot of that cost is by virtue of having that extra margin that comes with commercial payers. So there is a little bit of an inherent distrust, but there's also an incentive to say we're duplicating a lot of services, it's a lot expensive, can't we agree on appropriateness criteria, best practices, care redesign, so that we're not overseeing every step of every patient?
I think that's an important point to end on, which sort of cuts across everything we've talked about today, that Michael Porter talks about positive sum competition in healthcare, and ultimately we've got to get away from this zero-sum competition where it's a zero-sum negotiation. My gain as a provider is your loss as a payer. My gain as a physician is your loss as a hospital in an employed contract, and ultimately have this positive sum competition around value so that we build this culture of trust amongst each other so that we're all in the room, all trying to seek the same thing, which is try to improve outcomes and reduce cost. And that takes a certain amount of trust that you're not trying to do something to me or pull one over on me, that you're going to get a little better deal than I am. And ultimately, at the end of the day, the broader we can make the tent and get all stakeholders focused on value, I think the better outcomes we'll achieve. I just want to thank our panelists here for an outstanding discussion. This was extremely informative. I certainly learned a lot. I hope all of you learned as much as we did and enjoyed participating in this, or enjoyed viewing this as much as we enjoyed participating in it. I want to thank the Cleveland Clinic and Castlight for hosting us, and hope you'll all find this very informative.